Hello, everyone, and welcome to this webinar. My name is Val Morrison, and I'm a scientific advisor at the National Collaborating Center for Healthy Public Policy. Happy to be with you today to bring you this webinar on how institutions, politics, organizations, and governance shape the COVID-19 responses. We are going to be joined today by three presenters, and I will have the chance in a couple of minutes to introduce you to them. But before we get started, just a few housekeeping notes, and that is that we will ask you to use the chat box for any technical questions, any issues that you're having, trouble hearing, trouble seeing certain things, etc. Please put those in the chat box, and also use the chat box to discuss amongst yourselves. So make sure you send to everyone in the chat box, share references, questions, experiences, etc. And we will reserve the Q&A box for questions for the presenters, which we will get to after the three presentations. Today's webinar will be recorded, and that includes the chat and question and answer boxes. So please keep this in mind during your exchanges, that these will be publicly available on our website after the webinar. And then finally, for housekeeping questions, we will be sending out an evaluation form at the end of the webinar with an email follow-up, and we would kindly ask that you take the time to fill these out and share them with us. Many of you will know the National Collaborating Center for Healthy Public Policy and know that our mandate is to support public health actors in their efforts to promote healthy public policies. And we do this in three main areas. Those are through public policy analysis, intersectoral approaches to promoting healthy public policy, emerging and priority issues, and then two cross-cutting areas of concern, which are equity and the health of Indigenous populations. My team has put additional information about the center into the chat box, so please go ahead and consult that if you're less familiar with what we do. I want to take the time before we dive into the material today to acknowledge the territory that the NCCHPP is on and that I am on today, and ask that if you would like to, please post an acknowledgement for the territory that you are on in the chat box if you would like. So the National Collaborating Center for Healthy Public Policy is located in Montreal, and we acknowledge that we are on an age-old Indigenous territory, a place of meeting and diplomacy between peoples, and the site of the signing of the Great Peace Treaty. We would like to thank the Kanien'kehá:ka Nation for their hospitality on this unceded territories. So we are going to dive into the presentations now, and I have to offer my apologies to the presenters just seconds before coming online today. My notes, particularly my notes for the presenters' bios, crashed, and so I have access to the information that you do, but we are joined, so with apologies to Peter, Lara, and Sarah for not having your full bios in front of me. Dr. Peter Berman is a health economist, professor emeritus at the University of British Columbia's School of Population Health, as well as an adjunct faculty member at the Chan School of Public Health at Harvard University. Thank you very much, Peter, for joining us today. Our second presenter will be Dr. Lara Gauthier. Lara is a professor in the École de Santé Publique, or the School of Public Health at the University of Montreal. And our third presenter will be Dr. Sarah Allen, who is at the Dalla Lana School, associate professor at the Dalla Lana School of Public Health at the University of Toronto. So I will leave you in their very capable hands, and a reminder that we will come back after the three presentations with a question period. And you will see that during the presentation towards the end, the team at the NCCHPP has prepared questions that we think will be of interest to you. And we will be adding those to the Q&A box and encourage you to do the same, ask any questions of our presenters. And you can also use the upvoting function to vote for a question that you find interesting. And that way it gives us a sense of what the sort of common shared interests that we have in terms of questions and allow us to focus on those. And so without further ado, I will pass off to Peter Berman and take it away, Peter.
Okay, thank you very much, Val, and my colleagues at INSPQ and NCCHPP for this opportunity to share with you some of the work, as well as my colleagues who will be speaking after me, Lara and Sarah, and others who've been involved in our work. I am going to now hopefully be able to make things function properly. Let's see. There we go. I've taken control of the slides and now they work. So it's my privilege to introduce to you briefly this framework that we refer to with the abbreviation IPOG or IPOG. I'll start with this visual presentation. First, as you can see from the reference below, many people contributed to this work, which began in 2020 at the beginning of the pandemic in British Columbia. And essentially, we were motivated by a fairly simple question and observation, which is that during the early phase of the pandemic, a tremendous amount of information became available almost instantaneously around the world about the nature of the problem and some of the strategies to address it. But jurisdictions did very different things, often with access to the same information. And we asked ourselves, what could explain these differences? And we thought about this concept of upstream factors that were driving the behavior of governments and other organizations. And came up with this concept of IPOG, institutions, politics, the organizations that address public health needs, and the decision-making processes that they undertake. And as you can see from this chart on the left-hand side, the key focus is on the interaction or the interface between political structures and public health organizations in decision-making. And we use the term governance explicitly to refer to decision-making processes, and then how these influence decisions about what to do, and also the factors that influence the compliance with these decisions, both at the level of leaders and decision makers, and also citizens and communities, and of course, how this influences outcomes. So this is an effort to try to integrate some ideas from different academic disciplines to explain the behavior, especially of government organizations, in response to public health crisis. Now, just to spend a moment thinking about the definitions of these things, whoops, now let me go back. Thinking about the definitions of these things, we use the term institutions in the way that institutionalists in political analysis and economic analysis use it, which means the higher level formal and informal rules of the game. What it is that really drives people's underlying concepts of what is right, what is fair, what to expect. And I think it's important to keep in mind that we often use the word institution synonymously with organization. And in the IPOG framework, we made this a very clear distinction of difference. Political refers to the key political actors, their policy positions, and how they function in relation to government and the other organizations that are involved with crisis response. For organizations, we focused on trying to identify the public health system organizations It turns out this is not such a simple thing to do. There may be some formal structures, but there are often many informal structures. So who really was involved in decision-making from the public health side? And then, as I mentioned earlier, governance we defined very explicitly to focus on the processes of decision-making. The term governance has many definitions in the literature, and we narrowed it down to look at decision-making process. We do have a paper cited below which looked at how these things are defined in the literature, and we discovered that they are often not defined very explicitly. So this is a task in front of us. For the research design, we did some contextual work. We collected qualitative data from people involved in decision-making processes, and we focused explicitly on how IPO factors influenced the decision-making processes and the results. And for cross-jurisdictional studies, we look to produce comparative results across these differences that would be useful. And again, a citation which laid out the research protocol that was used for these. If you're interested in learning more about this approach, there's recently published a 3-volume set of studies. The first volume includes looking at the more traditional public health science-based approaches that underpinned some of the responses to the pandemic. But volumes 2 and 3 really look explicitly at the IPOG framework. And there are 15 case studies in this collection, including a number from Canada, other countries around the world. And I want to end my presentation really asking more broadly, what do you do with this kind of analysis? And I think this is the opportunity we have to think about the attention that preparedness, system resilience and response is getting around the world in Canada and in other countries, and to consider these IPOG type of factors as part of what we need to think about in better preparedness and response. For example, where does expertise sit and how open is it to diverse scientific perspectives, not just the explicit perspectives of biomedicine and epidemiology? What mechanisms are in place to create and manage the science-politics interface, and how well do they work? And what about more central and more local connections? We see in Canada and the United States, we have federal governmental systems, but even within provinces and states, we have province level and more local connections. And how are these organized? Can laws and regulations incorporate some of these insights for making future response more effective? And lastly, do we have the frameworks and methods we need for sound analysis and comparative learning? And explicitly, we have been struggling with how to do organizational analysis of public health systems, something that we need to do to make comparisons across jurisdictions and more effective response. So that's all from me today, and let me hand it over to Lara to continue with the presentations. Thank you very much.
Thank you so much, Peter. Hi, everyone. I'm very happy to be with you today. So Sarah and I are going to basically introduce some empirical illustrations of the IPOG framework based on our research called Upstream Determinants of Effective COVID-19 Response, learning from comparisons across Canada's provinces. So I wanted to take a little bit of time to acknowledge first our funders, so the Canadian Institutes of Health Research, CIHR, but also obviously to thank all the interview participants who participated in this research across the 4 provinces where we did the study. So basically in BC, in Ontario, in Quebec, and in Nova Scotia. And the table that you see here presents the different people who were involved. It was a very much team effort, and a lot of great people participated to collecting, analyzing the data, but also supporting our efforts in general. So the guiding question that we had for this specific comparative study was, how do variations in the politics, institutions, and organization of public health systems help explain the different policy decisions made across jurisdictions during the COVID-19 pandemic. And we specifically focused on the regulation of public spaces and COVID-19 testing policy. So what did we do? We proceeded in three stages. So the first one was really to understand better the context of our provinces. So we developed COVID-19 policy timelines, as well as organizational charts for public health systems for the 4 provinces. And we then conducted key informant interviews across different stakeholder groups involved in leading, influencing the pandemic response. You have all the breakdown of our interviews in each provinces below. So basically, the bulk of our interviews were done in 2023. We did some additional ones recently, especially for British Columbia and Quebec. Then once we had all of this information collected, we started coding the data and proceeded with thematic analysis. We specifically did a within province deductive and inductive coding, and also proceeded with an across province comparison, which is still underway as we speak. So a little bit more in depth into our empirical data. So in total, we have 107 interviews across the 4 provinces again. And here it's basically an overview of the different components of the IPOG framework and its relationship to our empirical findings. So to analyze institutions, we specifically looked at enforcement characteristics of rules and norms. We also looked at how essential services could be conceptualized in different provinces. We looked at the compliance of citizens, as well as the reliance of the scientific expertise in each of the provinces, and how this also structured the norms in each of these provinces. We have one study which really highlights these aspects, and particularly based on BC and Ontario data. And this is Sarah, who is going to talk to you more about it. For politics, we looked at legislature guidelines and order with specific policy decisions related to COVID-19, obviously. And I will give you more details about the study on testing, and then Sarah also will give some information about this specific component in the science policy advice comparative study. For organizations, we investigated the positions of different organizations engaged with COVID-19 response in each of the provinces, including experts. And we specifically emphasized our analysis on hierarchies, roles, accountability between and within key organizations. That aspect was specifically highlighted in a comparative study on organizational changes in the 4 provinces and throughout the pandemic. And the last component, again, in relationship with others, was really to try to understand who participated in the key decisions related to COVID, how were scientific and other forms of evidence introduced in each of the provinces and used also and mobilized in the key decisions, and how it did political actors basically influence key decisions. So that was the focus of the comparative study on testing, and also a Quebec sub-study that is still ongoing. So the first study that I will give you details on was on the testing policy across the different provinces. And so basically we tried to understand why the testing policies vary and diverge so much across the country. So basically, for this study, we looked at the different components, IPO, and then I will explain how this relates to governance. And what's important to say up front is that really setting priorities of the purpose of testing unavoidably really involved institutions, so the I component, and politics, the P components, and that had consequences on the organization component. So that's really a key finding here. So it was not really only about biological or epidemiological characteristics for the tests, but also obviously the norms in place, so the institutions and the politics at that time. So in terms of specific findings for institutions, we looked at professional norms and how, for instance, various provinces decided to use unregulated workers for testing, which also meant expanding scope of practices for a lot of them. So one of the interviewees said that there was a lot of pushback for this decision to be made from the health authority, saying that you can't train lay people to do rapid tests, like that's just, oh my God, the liability, oh my God, you don't have professional credentials. So it's really about saying that the time of COVID had a really interesting influence on the decisions that were made, because obviously this decision was made because of this specific crisis, but in other types of time and context, it would have been very difficult to be implemented. So really the emergency and the fact that politicians really wanted to reassure the population was more important than this professional norm, for instance. In terms of organizations, so the structure, obviously, of provincial laboratories, whether it was centralized or whether the provinces also utilized private sector, had an influence, as you can see here. The size of government policymaking units also had a strong impact. Basically, larger provinces had more bench depth and expertise, such as Ontario, whereas small provinces like Nova Scotia were able to capitalize on relationships of trust and familiarity to facilitate the policy development. In terms of politics, really what I was just saying is that politicians wanted to reassure the public. So this interviewee, for instance, is saying that it was all about helping calm fears in the public. And I think at different times, testing was used to do that. So it was really a political decision as well, obviously. And of course, societal factors also influenced professional perspectives. So some professions were more concerned with reliability and accuracy of tests, and while others focused more on accessibility and scope. And accessibility was obviously a major concern also for those who were concerned, again, about ethical and culturally sensitive response. So here there was this debate from the microbiology community about accepting tests for routine use that they would not have accepted outside of the pandemic. So again, special times oriented policymaking here. And then the links to governance. So basically how IPO structured governance here. So it was really a matter of technical accuracy for these tests, but also, again, a matter of public reassurance. But yet the decisions regarding the application and implementation of these tests really required considerable variety of contextual factors that we reviewed, especially the institutional aspects and societal aspects. And so the policies themselves varied across jurisdictions depending upon geography, capacity, culture, population, clinical perspective, and political judgment. Now on to the second study, we looked at how decision-making authority was exercised during the pandemic, how the advice of public health experts was integrated into decision-making processes, and lastly, how did the response coordinated between provincial and regional levels and also across sectors. So this is really about organization and reorganization as time moved along. Basically the components that we highlighted here, and then I will show you the links to organizations where institutions in terms of the reliance of diverse experts, Of course, we know about the Ontario example as a bit of an outlier with the science table versus others. And here I'm quoting someone who is saying, I never got the feeling that the government consulted experts in education, in ethics, in psychology, or any other disciplines to diversify the expertise around the table and consider the various impacts of decisions and reduce collateral impacts. So really, in most of the provinces, it was more a clinical and epidemiological aspect of expertise, which was favored. On the contrary, in other contexts, and such as in Ontario, which also involved other disciplines, it was not only this expertise that was valued. The political factors here was really focusing on how orders and regulation were adapted depending on the structure of public health, the structure also of the health system in general. Obviously, it was more difficult to adapt when in the case of hierarchical and centralized public health structures versus local and decentralized public health units, where in some cases, such as in Ontario, basically the local public health units were the ones who encouraged and inspired restrictions before the province actually took over on those restrictions as well. The role of chief public health officers also was very key. In BC, the public health officer was communicating directly to the public. And so that was, the person was really the figure of COVID-19 response and was seen as having more autonomous power perhaps than in other provinces. In terms of governance, then the single health authority was a key factor. So in terms of relying and coordinating resources for pandemic response, so especially in Nova Scotia and Ontario. Whereas in Quebec, which is a bit of a special case here, we have a decentralized health system, but it's still very hierarchical. So it made it easier to engage healthcare facilities, but it also made it more difficult to adapt for regional public health authorities to actually tailor some of the public health policies that were implemented. And then in terms of collaborative and concerted efforts with other sectors, that also varied based on the structure of the governance of public health and the health systems more broadly. And it often really came down to pre-COVID relationships in that case. So the links to organization here, it was really a two-way thing, right? So the IPOG structures the evolution of the organizations, but the structure of the public health systems and the organization of public health in each of the provinces pre-COVID also affected decision-making, advisory capacities, and coordination and adaptation of pandemic control measures. In terms of independence of chief public health officers, in terms of relationship between public health advisory bodies and decision makers, as well as centralization of health sector governance and embeddedness of public health within that governance structure. I leave it to Sarah now for the rest of the studies.
Thanks, Laha, and thank you to the NCCHPP team for the invitation to present this. Peter presented the overarching framework, and Laha walked us through two of our studies underway. There was a lot of data presented, and I think you'll hear some of the same themes starting to come up in the other two papers that I'll be presenting. Just note, though, these are works in progress, and we encourage you to ask us questions and share your thoughts, and we hope to be able to finalize and publish these in the coming months. But study 3 was really interested in this question of governance arrangements. It seems that it's moved. Hang on, let me just move back to the previous slide. Let's see, to study 3, where we're interested in those decision-making processes and the mechanisms that are influencing decisions, specifically around the collaboration and coordination of the diverse set of providers and organizations that are needed to sort of fulfill goals, whether it's during a pandemic or not. So we're interested in these governance arrangements as they played out during COVID-19, and specifically how health and non-health actors were linked up, whether formally or informally, to manage the emergency response. And here we illustrate some of the, we focus in, as Lara said, on one aspect of COVID policy, which is around the regulation of public spaces. So how decisions were made around what's open and closed and when, and what types of public health measures are needed in the various spaces that the public may want to use, and sort of decisions around the access and restrictions to these spaces. And I'm not going to provide details lined up with each of the component of the IPOG framework. Many of them are cross-cutting, and here I am interested in sort of institutions and governance, but decision-making was highly political, so it's really hard to separate out, I find, the different components of the framework, but in its entirety, it's really enlightening and helps to understand more about how and why decisions were made. And what we were finding, for example, leveraging some of the data that we collected in British Columbia and in Ontario, that there was this sort of a divergence in these governance mechanisms or approaches that we saw, where within government, for example, there was a very formalized and explicit mechanism to connect and coordinate health sector with other non-health sectors, and that's sort of government ministries or departments. And these, many of these were already existing in British Columbia, such as the Emergency Management BC unit, which is an existing entity that's responsible for coordinating across ministries during emergencies. And then other more ad hoc mechanisms for collaboration that were set up, primarily led by the public health officer in the province of British Columbia, where there were established committees that were chaired by the public health officer in order to allow for diverse perspectives across these sectors and among ministry leads who were responsible for considering their own industries and sectors to weigh into some of these decisions that were made. And this was more formalized and explicit than was seen in the province of Ontario, where interviewees spoke about the kind of the locus of this inter-ministerial or intersectoral deliberations and collaboration was primarily in the cabinet, behind the sort of the closed doors and in the privacy of those cabinet discussions, where ministers representing all of those different portfolios that were linked up more through committee and other sort of lower levels of the bureaucracy in British Columbia, those weren't taking place until they reached at the ministry level within the cabinet itself. And so this was, a point that came up among many interviewees as an area that may be considered in terms of what lessons we can learn from the British Columbia experience, for example, but also differences emerged within the sort of arrangements for collaboration between government and non-government actors. On the similar theme of, health and non-health intersectoral kind of considerations, instead of looking within government at those mechanisms that link up ministries and different portfolios within government, here we're looking at the mechanisms that were enabling a collaboration between government actors and non-government actors representing those various health and non-health interests. And again, these seem to be more formalized in British Columbia, where there were seen to be across multiple interviewees many points of access to government, where people representing a particular industry could hear and have a voice in sort of understanding and shaping government policies with regard to the pandemic. There were some structured engagement, again, led by the public health officer in the province to engage certain communities and allow for industry representatives to sort of shape and just have a pretty significant role in in shaping and influencing and having a say in the way the public health measures were developed that were really implicating their industry specifically and directly. This was seen to be more limited in the province of Ontario, where explicit consultation among health sector leads who would be sort of responsible for the pandemic emergency response within the health sector, were the limited engagement with at the provincial level with non-government stakeholders. And it was seen that the Ministry of Health and the representatives there were less accessible and less outwardly sort of engaging these non-health sector representatives. And that most of the engagement that was happening was done primarily at the local level versus at the province level in Ontario, for example. So those were just some of the findings that we wanted to touch on that were related to the governance arrangements that sort of helped to, point out the difference in decision making that we saw across provinces. But another sort of puzzle that we were interested in looking into and helping to sort of shed light on was this, whether the differences in the way science advice was solicited and organized and informing decisions, whether that varied, and does that matter in terms of impacting decisions in the provinces. So a separate study is in development looking at this. We know that there's an urgent need for scientific advice generally and to inform public health and health policy decisions, but especially so during an emergency and a pandemic, as it played out in terms of generating and disseminating and continuing to be aware and responsive to the evolving advice coming from scientists. And we also know from the literature that these mechanisms for soliciting and providing scientific advice face many tensions. On the one hand, scientists need to be independent in order to fulfill their research objectives and ensuring that there's not too much influence on the process by government or other decision makers. And on the other hand, scientific process sort of requires this openness, and being open to public scrutiny and peer review is really central to science sort of processes generally. And so a need to kind of ensure that an open process, but while maintaining confidentiality of internal and government information. And so the ways that governments and the provincial governments in particular addressed these trade-offs and sort of grappled with these decisions did vary across the provinces. So we were interested in understanding more about that. How did it play out and what impact did that have on decisions? And so some of the emerging findings from this study relate to obviously the Ontario context being unique in terms of what drove the sort of emergence of this new entity that was the Ontario, COVID-19 Science Table, that leveraged the robust infrastructure that existed across multiple universities, where we have many public health schools. So there's a lot of, existing sort of capacity within that space that was leveraged, but at the same time, a limited capacity with underinvestment in the agency that had been initially tasked to fulfill this role at Public Health Ontario. So simultaneously sort of empowering a more voluntary arm's length body to be established. Given the dispersed nature of this expertise in both epidemiological and other modeling expertise and in public health through this rich network of universities. So this is a bit unique, and it sort of helps to understand the sort of origins of this science table, which was unique to Ontario. But across the board, we did see some commonalities in terms of how existing structures and constraints impacted the science advisory processes, which is really a limited data infrastructure to rely on in order to inform government decisions. That was fairly limited to health, like hospital-centric data, limited data linking and sharing across sectors that allowed for more robust kind of monitoring across different industries and tracking of the virus in itself, but also looking at health and non-health considerations in establishing the sort of, the research that can be undertaken. And sort of the limited data set also impacted the modeling and the types of data that were provided to decision makers, which then led to a reliance on sort of additional mechanisms outside of these science advisory mechanisms to really weigh those health and non-health considerations more explicitly. So this wasn't done within these primarily public health and epidemiologically driven science advice mechanisms. But we did see some variations also in the level of sort of privileging independence versus sort of, privileging confidentiality and close proximity to government, where in Ontario there was a much more sort of independent arm's length approach, which, was on the one hand seen to be helpful in terms of bringing, more public awareness and publishing reports that were then, shared broadly through different media. This may have contributed to more stringent measures in this province and was seen to sort of start off with, at the initial stages of the pandemic being quite supported by government and quite influential to government. And then over time, this level of influence seemed to wane. And, this tension around scientific advice being, shared publicly outside of government channels was, there was different views on how this, who should lead public communications in crisis. Should these be independent scientists or government and other public health officials? And then within other provinces outside Ontario, such as BC approach, we're leveraging the robust science advisory mechanisms within government agencies, and the BC CDC is the prime example, was also seen to be highly influential in advising and informing government. But then, in this approach, the government was weighing more heavily the sort of impacts and influence on government than ensuring public transparency and openness to scientific scrutiny. So a different weighing of the trade-offs that we saw here. And I'll just leave with a few sort of remarks, and then we're really excited to open up to questions and hear from you. But, questions remain from this work, but we're curious to sort of, lay out like what could be some of the learnings from this variation that we see, and whether, the approaches that we've seen to enable a kind of existing mechanism for both eliciting science advice, but also ensuring intersectoral collaboration, how to weigh the sort of planning and development of these processes, in preparing for future emergencies versus being nimble and adaptive and being able to structure and to set up these committees and mechanisms as needed as pandemics evolve and take different shapes. So perhaps balancing those, formalized structures with, more adaptable and nimble processes may be sort of a consideration for future. So yeah, we look forward to your questions and comments. Thanks so much.
Thank you so much to Peter, Lara, and Sarah. I'm still wrapping my brain around some of this information. Really very interesting findings and interesting and original ways of looking at the interaction between the COVID-19 pandemic and how policy and decisions are made in connection with organizations and the links between them. I was reminded as you were speaking towards the end of some work that we've done in the past on wicked problems and effective ways for resolving wicked problems, and wondering, and I won't ask you to comment on this unless you want to, but one of the distinctions in an emergency is that decisions are made much more authoritatively. They need to be made much more quickly. And as we move towards increasing wickedness or complexity, especially social complexity, those start to require much more collaborative solutions, including collaborations with different types of organizations, but also with populations. And I was thinking of the change that we saw over time, and you mentioned how things changed a little bit as the public grew tired of the rules and tired of the pandemic, and there was more pushback. And I wonder if we move then from the sort of the emergency decision making and that's more authoritative towards something that needs to be much more inclusive in order to be effective. But I just wanted to share that because it came up for me while you were speaking. But I want to introduce everyone to Martin Renaud, who's going to look at the questions with us. And I saw that there were a number of questions in the question box, and people are expressing their wishes in terms of what they would like to see answered. So just before we get to that, I just wanted to say quickly, in case anyone who's listening to the recording or anyone who has colleagues who would like to listen to a French version of this webinar, we will be doing that in 2 weeks on February 13th. Alors, je m'adresse aux collègues francophones. Nous allons refaire ce webinaire, une version quasi identique avec une ou deux présentatrices différentes, mais c'est le 13 février à la même heure, soit à 14 heures. Et je crois que nos collègues ont mis le lien vers les inscriptions pour la version française dans la boîte de clavardage. Donc, that's just a little plug for the French version of the webinar. And I will ask now, Martin, if you would like to select and read out one of the questions that's been inserted into the box and maybe received some votes.
Yeah, thank you, Val, and thank you, everyone. Thank you, the presenters, for a very interesting presentation. So as Val just said, you can still vote or put new questions in the Q&A. I will just go in order of vote. So the first question for anyone who would like to answer it, based on your research, what key lessons should policymakers prioritize for future pandemic preparedness? A wide question, I guess.
Should I take a first crack?
Yeah, go ahead, Peter.
So, thank you. First of all, there are many, many difficult and stimulating questions there, so I'm sure we're not going to get to them all. I think that one of the key lessons from our work is that we should not see preparedness only in terms of the technical inputs that are needed. Often we think about this as more labs, more personal protective devices, stockpiling of things. And I think we need to look at the organizational structures and the linkages between those and local and higher level authorities, political structures, and so on, as part of the preparedness planning process. It's not that there's a single answer for every jurisdiction. Some of these things are path dependent and contextually dependent, but they need to be explicitly looked at. I think that's the key lesson from the IPOG framework.
Sarah and Lara, would you like to add anything there?
Not much, but maybe just wise balance of some degree of centralization for fast decision making, while allowing for adaptability of policies in different locations to allow for, again, adaptation to the context and the social, cultural, historical, political factors.
Right. So those kinds of lessons that we know, but we need reminding of often that context matters a lot. Martin, do you have another question?
Yeah, a more specific question this time that was the most voted. So, immunocompromised patients continue to feel the impacts of COVID. How do we have institutions, organizations recognize groups of patients? How to continue with protective measures for groups that continue to be disproportionately impacted?
That's sort of the reminder of the ongoing nature of the pandemic there, especially for certain groups. Can I put you on the spot, Sarah, since you didn't respond to the last one, and see if you have anything to say? Don't feel that you have to respond,
Sure.
but
No, it's a really good question, and it's something that we looked at in a more general sense in terms of how the unique communities and population needs are being considered within, often very blunt public health measures and instruments that are used in a pandemic. And so we did, include many of our, many interviewees spoke about the different efforts that were taken to consider the diversity of needs, but this was something that came out more as a shortcoming than as a strength. And so I think one of, maybe tying back to the first question, and one of the lessons learned is establishing some of these mechanisms for ensuring that all that rich local level, whether it's at a health clinic or a public health unit or community organization level, where that's where needs are understood and more adequately engaged in terms of prioritizing certain communities that may be left out or not heard. But how do we ensure that knowledge is shared in a open and sort of open learning approach with decision makers who are often quite removed from that level? So those mechanisms for sharing the learnings and knowledge held locally to decision-making tables is an area that I think is an opportunity for strengthening preparedness for the future pandemics, but also addressing these unique needs that were pointed out in the question.
right. Peter or Lara, would you like to add something? We'll go on to the next.
Yeah. So next question.
I think Peter was going to add.
I think one thing we learned from the pandemic is that control measures have justifications and have consequences, which we need to be able to consider. Sometimes there are trade-offs that don't have a perfect answer to them, right? But as Sarah said, maybe we need to have mechanisms for addressing some of the specific needs of certain populations and creating spaces for those and justifying that to the public more generally.
And finding mechanisms for knowing what's there before we need to know it, right? Martin, you have another question?
Yeah, next question. So, was there any sense of where the government was in terms of proximity to an election, in terms of being more or less risk adverse? So, Nancy gives the example of the Nova Scotia Premier was not standing for re-election after the pandemic.
Anyone volunteer to take a stab? You've seen I'm willing to single someone out.
I think it's a tricky one. I mean, I think to some extent, political elections did have an impact, but correct me if I'm wrong, Peter and Sarah, but in our data, it was not the key element which had an influence. I think that regardless of the political party of the government in power at the time or the proximity to elections, governments really wanted to show that they were acting, that they were doing something. And I think that was the key. Again, public reassurance in terms of testing policies, but also in terms of regulating public spaces. So, I think, I don't know if you wanted to add to that, but I think, yes, to some extent it did have an impact, and perhaps for Nova Scotia in particular. I know for Quebec, for instance, it perhaps helped the government at the time to get reelected, because I think the general opinion was that in the province was that COVID was rather well handled for Quebec, but by the ministry, the government in place. But I don't think it was the major factor.
I'll add one thought on this. We looked at this in a number of the international case studies as well. And there was a question that emerged in a number of jurisdictions when emergency restrictions could have limited the participation of the electorate in the elections. Did this influence the subsequent legitimacy of the government to provide the leadership that was needed? And in some cases, governments actually removed these restrictions in order to not jeopardize their future legitimacy. So this is an important interface between the public health needs of an emergency and the political legitimacy processes.
Absolutely. We have time for a couple more. Do you have one ready?
Yeah, another question about misinformation or disinformation. So Justin is asking, where and how do the impacts of mis and disinformation impact the IPOG framework? So he's referring specifically to the impact on social fragmentation, for example.
I guess I'll weigh in here, but the IPOG framework can kind of help to tackle any type of question that is about sort of how decisions were made and how different influences externally and internally to sort of government and public health organizations, how they impacted these decisions. So with regard to misinformation, if the question is, how did leaders of the pandemic response kind of address or consider the their mitigation strategies for misinformation, or how did they perceive the role of misinformation in affecting public health, public support, and so on the policies, then IPOG framework can help us. We didn't ask that question specifically, but we did ask around the sort of role of social media and noise and backlash, and this came up as being influential in terms of decision makers weighing these and reviewing the noise and the discontent and sort of a lot of the feedback mechanisms they get through opinion polls, but also through social media, as being influential in decision making, and it became more and more so over time. And this was seen across provinces. But again, it wasn't about misinformation specifically, but I think it's embedded within it, and a specific research question that focuses on it could use the IPOG framework and the way that we've been tackling many different sub-questions within this broader study.
Can I add one quick thought there?
Of course.
I think this is a very important element. Obviously we learned during the pandemic that trust in science and evidence was a key factor in many jurisdictions. So where does that trust come from, and how does it relate to the institution part of this, which is, people's understanding of what is science, what is evidence based on science. And I think all the decision makers involved had to learn quite a bit about that. And that's the counterbalance to disinformation or misinformation. So.
We're getting very close to the hour here, but I was particularly intrigued. I think it was one of your first slides, Peter, that asked the question, where does expertise sit in this, and particularly how open are we, or our governments and science organizations, to diverse perspectives within science? That's something that we seem to be, I mean, it was patently obvious during the pandemic, but much more generally, we're living in a time where there's competition to define truth, and the whole question of expertise has been kind of thrown up into the air, and we're not yet sure, I think, where it's going to land. So I wanted to ask each of you in turn if you could give a sense as we close out the webinar of how you would answer that question. of how did expertise sit within your study? What role did it take on? And where do you think we are as a field in public health and policy in terms of the role of expertise?
Yeah, I think it's a really important question. I would say I was going to add to that other question, and also to a very similar question that was asked by an anonymous person on the chat. I think the diversity of disciplines that can be considered actual expertise is super important, and that was something that was really overlooked. I think I touched upon this during the presentation, the fact that in most provinces, the expertise that was always put forward was the one from public health, epidemiology, evidence-based medicine. So, and I think it's really important to try to not have this narrow vision of what science is and expertise is, and give more voice and space to the social sciences. And I think that was not done completely appropriately during COVID.
Thanks. Interesting comments. Peter and Sarah, do you have something to add to that?
I would certainly support what Lara said, and you know, as an educator, and I think, are we sufficiently training people in public health and health systems to be prepared with that background in social sciences to ask those questions and be able to interact with other types of expertise that clearly became important during the pandemic?
Okay, thanks. And Sarah, final comment?
Just to echo my colleagues and to sort of point out that I think one of the commentators spoke about the sort of a lot of diverse people became experts, and those that maybe were experts weren't considered. So I guess it's rethinking sort of what are those mechanisms to ensure a broad and diverse sample of experts weighing in on scientific advice for governments, but also balancing that with the noise that comes in with the, you know, everybody's an expert type of thing. So I think balancing and just being more explicit about, you know, how government's decisions are being made and what's informing them, and being transparent about these decisions is, you know, something to think about in you know, bringing people on board and increasing trust, but also openness of the scientific process to ensure it can be, you know, tested and open to scrutiny.
Great, thanks. Well, here's hoping that people are listening and that we're all listening too, right? Because these are things that we have to keep moving forward. I want to take the time to thank the three of you. I feel like we could spend the entire afternoon and still be passionate about it for a couple more hours, but we are at time. So I want to thank you for joining us today and for sharing your research with us. I think it's informative, it's innovative, and it's important research for us as a field to think about as we prepare for other public health emergencies. I also want to take a second to acknowledge my colleagues, Martin, Alexandra, and Mylène, for all their work towards bringing us this webinar, and remind you that I believe the link has been put in the chat for the evaluation of the webinar. We pay close attention to your comments and feedback as we prepare other events. So we would appreciate the time that you take to do that. And with that, thank you one more time and wish everyone a great end of the day. Bye-bye.